So the majority of the lecture we should speak about the coagulation and about thrombocytes, yes? About leukocytes I will tell you at the end of the lecture about 10 minutes, yes? So the majority thrombocytes and coagulation, together they do hemostasis, yes? So the stoppage of bleeding. And after this lecture you should understand how to stop the bleeding in our body, yes? How it works. You know, to stop bleeding, that's a very good thing, yes? Why is it good? Yes. The problem is that without hemostasis, you will die in few minutes or few hours, yes? For every minute, you have some small injury of your blood vessel, yes? And these small injuries has to be repaired instantly, yes? To do this instant repair, we have thrombocytes. If you have some bigger damage, then we use the coagulation factors. But unfortunately, there are also some negative effects of the hemostasis. You know that about 1/2 of the European population die due to some cardiovascular diseases. And the difference between stable cardiovascular disease and unstable cardiovascular disease that can kill you is the hemostasis, yes? For example, if we focus on the heart, we have stable form that is called stable angina pectoris. And there is a problem that we accumulate the cholesterol and other compounds in the blood vessel wall, and therefore the blood vessel is narrower and narrower. But this is the stable angina pectoris. What can kill you? That's the heart attack. And in this state, on this plaque, you start the hemostasis. And this hemostasis on this atheromatous plaque is able absolutely to close the blood vessel, and that can kill you. And that's the difference between stable cardiovascular disease and unstable cardiovascular disease. The difference is hemostasis, yes? Also, a lot of people in hospital die due to sepsis. That's the generalized infection. And a lot of these people die due to imbalance in hemostasis that is called DIC. That means disseminated intravascular coagulation, yes? It means that in your whole body you start a hemostasis, yes? From these two negative effects, you understand that for proper hemostasis, you need to have two conditions. To start the hemostasis at proper place, so only on the place of the injury, and also to have very good control on the hemostasis, yes? For only if the hemostasis is balanced, that it cannot spread through your whole body, yes? If one of these conditions is broken, you can die due to it. Today I will mix two terms, the hemostasis and the hemocoagulation. The difference is that hemostasis is broader term. It means it includes all phases how to stop the bleeding. And if you want to stop a bleeding, you will use all factors how to do it. The first factor, if you have injury of blood vessel, the first factor is the reflex vasoconstriction, yes? So if you do the injury to the blood vessel, the answer is constriction, yes? And if you constrict the blood vessel, the injury will be smaller, yes? The second phase is the thrombocyte activation and aggregation, yes? Thrombocytes are the second defense against bleeding. They are used especially to treat the small injuries, yes? If the thrombocyte action isn't enough, then you start the third phase of hemostasis, the hemocoagulation. Hemocoagulation is the transformation of soluble fibrinogen to insoluble fibrin clot. And then, if you stop the bleeding, then after the injury repair, you have to destroy this fibrin clot, and that's called thrombolysis, yes, or fibrinolysis. So hemostasis has these four phases: the vasoconstriction, action of thrombocytes, hemocoagulation, and delayed thrombolysis. The hemocoagulation means only the conversion of fibrinogen to fibrin, yes? So that's the difference. So coagulation or hemocoagulation is only one phase of hemostasis, yes? Hemocoagulation is catalyzed by some enzymes, by some proteins that we have in blood, yes? And together, these coagulation factors that we have in blood produce a big cascade. And at the end of this cascade, we have the conversion of fibrinogen to fibrin. Yes? So there's a difference between hemostasis and hemocoagulation. Majority of the coagulation factors are zymogens, proenzymes. Yes, they are inactive. They are synthesized in the liver as inactive proenzymes. And they are activated by partial proteolysis. Yes? The same as the pepsin and pepsinogen, trypsin and trypsinogen. Yes? In your digestive tract. I think that about the pepsin and pepsinogen you heard in the winter semester during the lecture about enzymes. That's true. Not about the coagulation factors. So that was the overview, yes? What is hemostasis? What's the hemocoagulation? I will skip the reflex vasoconstriction, so I will go to the second phase of hemostasis, the action of thrombocytes. So, you know what thrombocytes are, yes? They are the fragments of megakaryocytes. Here we have the number. The numbers you have to know, yes? That you know. In the previous lecture, I said to you that you have to know the levels of compounds in plasma. And after this lecture, you have to memorize the levels of thrombocytes and then the levels of white blood cells. From histology, you should know that the thrombocyte we can divide into two zones. Do you know these two terms? Yes, so granulomere and hyalomere. The second, that's the peripheral zone, yes. And this peripheral zone is composed of the invagination of the membrane. And this peripheral zone is important for the secretion, yes. I will tell you later that one of the thrombocyte action is the secretion to produce active compounds, for example, eicosanoids. And to produce these compounds, we need the peripheral zone. Then we have the second zone, the granulomere. And in this zone, we have 4 granules that you also know from the histology, I think. Yes? That we have the dense bodies, then we have the alpha granules and the lambda granules. For the coagulation, we will use these 2. In the alpha granules, you have peptides, yes? We have there the fibrinogen, that's the coagulation factor. Other coagulation factor is this, that's the von Willebrand factor. That's von Willebrand factor. Von Willebrand factor is important for the platelet adhesion to the injury. Then these 2 things, these 2 abbreviations, what does it mean? So both are growth factors, and these growth factors are important for the repair, yes? So they are important for the reparation of the injury. And then here we have the thrombocyte factor 4 that are the phospholipids. Yes? We need the phospholipids. For the phospholipids enables the coagulation factors to accumulate in the place where you have injury. Yes? The coagulation factors are bound to these platelet phospholipids, and then they can accumulate only in the place where you have platelets, and they are only where you have the injury. So this is one way how to localize the coagulation only where it's necessary. So all these granules are important for vasoconstriction, coagulation, platelet activation, and then the repair. About the metabolism of thrombocytes, the metabolism is quite simple. They have no nucleus, and therefore they have no proteosynthesis. So everything they have to have from the megakaryocyte. Yes, they cannot synthesize any new protein. But they have very intense metabolism. They use the glucose as their energy source. And the energy they can use for these contractile proteins. The platelets are able to change their shape. Yes. Normally they have disc shape, and after activation they will change their shape due to these contractile proteins. And we will speak about the thrombus retraction. Yes, for they are able to retract the thrombus and to put it only on this place of the injury. And also the contractile system is important for the release of granules. Yes, you will take the granules and you will put them out the cell, the exocytosis. And then also in the membrane they have the phospholipids that are important for the activation of certain coagulation factors. Where you think we have the phospholipids that are important for the coagulation? Where in the membrane? Outside or inside the cell? Or we have two layers? So where you think we have the factors, the phospholipids that are important for coagulation? Here we have intracellular, and here we have extracellular. If you have them extracellular, then the coagulation factors can bind to them, and you will start a coagulation. Yes, so normally they are inside the cell, and then there is some enzyme that is called translocase that gives. There is one enzyme that can change the composition of the outer and inner layer of the phospholipids. Do you know how it's called? That you should know from the winter semester. It's called flipase. For this mechanism, it's called flip-flop mechanism. Yes? Or the older term, I think, is scramblazed. I think due to scrambled eggs, yes? But remember flipase. That's important enzyme for the thrombocytes. For after activation, they can put the phospholipids from the intracellular pool to the extracellular pool. And then they can start the hemostasis. Yes? And now how the platelets do the hemostasis. So there are 7 phases how the platelets do the hemostasis. The first If you have injury, the first phase is that you have to accumulate the platelets in that place, and you have to bind the platelets to the injury. So the first phase is the adhesion. Platelets, if you have injury of blood vessel, then the endothelial cells are destroyed, they are out, and under the endothelial cells you have what? Yes, and between smooth muscle and endothelial cells you have smooth basal membrane when you have collagen. Yes? So, thrombocytes bind to the subendothelial collagen. Yes? Normal endothelial cells produce factors that prevent the thrombocytes from adhesion. Yes? If you remove the endothelial cells, thrombocytes will bind to the collagen. And this bond is done by the von Willebrand factor. The von Willebrand factor has two binding sites, one for the collagen, that's here, and then the second binding site is for thrombocytes. And on thrombocytes we call the receptor glycoprotein 1b. Yes? Later we will speak about second glycoprotein. So this is the first glycoprotein, glycoprotein 1b, that enables the adhesion. Von Willebrand factor, collagen, and glycoprotein 1b. If the thrombocyte binds to the collagen, that's the signal that the thrombocyte should activate. Yes? Therefore, we have the second phase that's called activation. Thrombocyte can be activated by many things. Yes? But to do it simply, we will say that it's activated by the collagen. And then you will understand, after the end of the lecture, you will understand that it's also activated by these other factors. Yes? But now, to make it simply, we have the thrombocyte, there is adhesion to the collagen, and this adhesion activates the thrombocyte. So, if you activate the thrombocyte, you will start three processes in the thrombocyte. The first process is the expression of the glycoprotein 2b, 3a, that's the receptor. Yes? It's the receptor for fibrinogen. So that's the first process. After activation, the thrombocyte will express new receptors. And you see that it's very potent. For one thrombocyte can have 100,000 receptors in the membrane after activation. Yes? The second process is that the thrombocyte starts to produce active compounds. Compounds that start the hemostasis, that maintain the hemostasis and start the coagulation. What's this? What? Thromboxane A2, yes? And was it thromboxane A2? You had lecture about it. Eicosanoid, yes. Is the eicosanoid, and is the eicosanoid that does vasoconstriction, it starts hemocoagulation, or better it's to say to start the hemostasis. It activates the thrombocytes. Yes, here you have it. So you see that after activation with collagen, thrombocytes are able to produce factors, thromboxane A2, that activate them. So this is the positive feedback. Thromboxane A2, that's the compound that is important to induce the hemostasis. And do you know the opposite compound that acts against the thromboxane A2? Yes, prostacyclin. So you can say that this is the bad one. This is for the inflammation, vasoconstriction, and so on. And prostacyclin does the vasodilatation. It's against the aggregation, anti-inflammatory effect has. Yes? And the prostacyclin is normally produced by the endothelial cells. Yes? So normally the endothelial cells produce prostacyclin, and this prostacyclin inhibits the thrombocytes. Yes? And thrombocytes produce opposite factor. And the third process after activation is the shape change. Due to contractile proteins, here we have disc shape, and here you have the shape with many hands. Yes? Amoeboid shape is called. Yes, as the small amoeboids. So that's the third difference. So 3 processes after activation: expression of new receptors, for example, glycoprotein 2B3A, production of active compounds, and then the shape change. If you do these 3 factors, you can start the third phase. That's called aggregation. So put the thrombocytes together. So on this picture you have already the third phase, the aggregation. Thrombocytes are bound together. How to do the aggregation? We will use the receptors that were put in the membrane in the second phase. So we have glycoprotein 2B3A receptors that can bind thrombocytes together if you have fibrinogen. Yes? So for the adhesion, we used von Willebrand factor. And now for the aggregation, we will use the fibrinogen. Yes? You know the name of these glycoproteins, you should know. For today, we use the antibodies against these glycoproteins. And for example, if you have patient with heart attack, the treatment is to do what? If you take him to the cardio center, what you will do with him?
You will do like an intracardial catheter?
Yes, so with a catheter you will make, how it's called?
Dilation?
Yes, dilatation of the wall. And you know, if you do this dilatation, the side effect is that you destroy the blood vessel also, and a lot of endothelial cells are destroyed. And to stop the coagulation, all patients with this during the procedure gain the inhibitors of these receptors, for you will stop the aggregation. So therefore you have to know how it precisely works. For in pharmacology and cardiology they will want you to know it. Yes? So therefore I go so deeply in the mechanism. We can distinguish 2 phases of aggregation: the reversible aggregation and the irreversible aggregation. The primary or reversible aggregation is the process when the thrombocytes heal some small defects. Yes? Every second in your body occur many defects in your blood system. Yes? In your circulation. And majority of these defects is treated by the thrombocytes. Yes? If you end the hemostasis at this stage, so it So if you end the hemostasis here, we are speaking about the primary hemostasis, only thrombocytes. But if the platelet aggregation continues to the 4th phase, that is called degranulation, so the thrombocytes release their granules, we are speaking about the secondary hemostasis. For this irreversible aggregation, it means aggregation with degranulation. This together starts the hemocoagulation. So aggregation is done by fibrinogen, by glycoprotein 2B3A. And we have two possibilities to do the reversible aggregation to heal small defects, or if you have very big defects, you do the secondary irreversible aggregation that is associated with degranulation. And degranulation, that's quite simply, you have three types of granules, and thrombocytes in this phase release these granules. Yes? So all factors that were in the granules are released. So there was calcium, there was fibrinogen, there was ADP, there was thromboxane A2, there were growth factors, and all these things are released. That's the degranulation. And then the other phases are the connection of the thrombocyte action with the coagulation. Yes? About this I will tell you in the part with the coagulation. Yes? So do you understand how the thrombocytes do their action? The first is adhesion, so they bind to the injury site. They bind to the collagen. The second is the activation. In activation we start three processes. So secretion of active compounds, the expression of new receptors, and the change of the shape. In the third phase we have aggregation, so the thrombocytes bind together, and here we have to decide whether the thrombocytes are enough to stop the bleeding or to cover the injury. Then we will stop here and we have only the primary hemostasis, or whether we have to continue and to call the hemostasis, the hemocoagulation. And then the seventh action in hemostasis, thrombocytes have growth factors inside. They have fibroblast growth factor and then platelet-derived growth factor. And these factors are important to repair the injury. So here you have one scheme. You can look at it at home. Here is everything what are set to you, yes? Adhesion, activation, shape change, reversible aggregation, degranulation, irreversible aggregation, yes? And how it works. Something is in check, for example here collagen, but I think that you will understand it. I put only the things that are really different from English. So that was about thrombocytes. Do you understand? Do you have any question? So now we will start with the coagulation. At first I have to tell you that in your books you can read two models of hemocoagulation. We have old and new, or you can say revised model. I think then in majority of your books you will read this old model of hemostasis. Yes? This model is quite old and it works quite good. Unfortunately, in some severe states it isn't able to predict the state of the patient, and therefore it was produced this new model. Yes, that is better. That can be applied better in vivo. Yes. The old model you should know with this model you can understand how to do the coagulation tests. Yes. For the coagulation tests were prepared according to this old model, and to understand them you should know how it works this. Yes. So therefore I have to tell you both models, but for the medicine you should remember this especially. This new revised model. It's also simpler than this old, but this you unfortunately have to know due to the coagulation test. The old model is based on three pathways. We have extrinsic pathway, and intrinsic pathway, and these two pathways joined together to do the common pathway. Yes? It means that due to the old model, you have two possibilities how to start the hemostasis. One possibility is called extrinsic pathway, the other is called intrinsic pathway. But at the end, both these pathways should join in the common pathway. And here in this model was postulated the coagulation cascade, yes, that we have the partial proteolysis. In the new revised model, it's based on the old model, but due to this new model, we know that there is only one start, yes? And the start is in the extrinsic pathway, not in the intrinsic pathway. And we know that in vivo, it happens that only the extrinsic pathway is important for the first phase that is called initiation. Then you have two other phases, amplification and propagation. And for these two other phases is important the intrinsic pathway of the old model. Yes? So the difference, you can say that in the old model you have two pathways and then the common pathway. And in the new model you have the extrinsic pathway, then you have the intrinsic pathway, and then you have the common pathway. Yes? So it's the set of reactions. And due to this new model, the extrinsic system is important, and then the thrombin, that's the molecule of the common pathway. Yes? But I say to you that in the books, I think in most of the books you will read only this old model. Yes? For this new model was discovered at the beginning of the century, or was postulated. And in the books you have it from 2009 or 8, something like that. So we will start with the coagulation factors. Yes, the coagulation is based on the coagulation factors that you have in your plasma. And these coagulation factors are produced mostly in liver. Yes? There are some exceptions. For example, calcium isn't produced in liver. Yes? But majority of the coagulation factors is produced in liver. And therefore, if you have patient with liver failure, for example, with liver cirrhosis, one symptom will be bleeding, yes? Or at least prolonged coagulation tests. The coagulation factors are marked by Roman numerals, yes? Here you have their names, but in all schemes we will use only the Roman numerals, yes? And all coagulation factors can be divided into 5 groups. Most coagulation factors are serine proteases. So they are enzymes that degrade other enzymes or other proteins. Important is that they do only the partial proteolysis, yes? So we can say that they activate the other enzyme, and therefore we have the coagulation cascade. Second big group are cofactors, yes? Some coagulation factors are proteins that are cofactors of these proteases.
So excuse me, those proteases, they cleave some inhibiting proteins?
You have the proenzyme, inactive enzyme, and this protease removes some small chain, peptide chain, and it activated. Third is calcium. Yes, calcium is important for the coagulation. Calcium is important for bond of the coagulation factors together, yes, or to bound the coagulation factors to thrombocyte. Then we have the fibrinogen. Fibrinogen isn't protease. Fibrinogen is factor that can convert to fibrin, and fibrin can do polymeration. And the last factor is transglutaminase. Transglutaminase is able to produce covalent bond between fibrin. So all these 12 coagulation factors can be divided into these 5 groups. Here you have the list of the coagulation factors. I will tell you briefly to all of them. I think that all of you will discover that here we have 1, 2, 3, 4, 5, 7, 8, 9, 10, 11, 12, 13. So what is missing? 6. How is it possible? Is there a mistake or not?
Maybe it was thought to be a factor and then wasn't after all?
Yes, there was the factor 6, and it was discovered that factor 6 is activated factor 5. Yes? You have 1, that's fibrinogen.
Do you want us to memorize all these?
Yes, and that's not all of them. We have about 30. But only this I think you will use in the cascade. 1 means fibrinogen, 2 means prothrombin, and if I put there small a, so 2a, it's activated 2. Yes, so it's only thrombin. And you will of course discover that only the proteases can be activated. Yes, so we have 4a. 4 you cannot activate calcium, for example. Yes, so in your books you will read 1, 2, and for example 2a, and difference between this is partial proteolysis. Yes, this is active form, this is proenzyme. So briefly to all these factors. Fibrinogen, that's the end protein. Fibrinogen does fibrin clot. Prothrombin, active form is thrombin. Thrombin catalyzes the conversion of fibrinogen to fibrin. Tissue factor is important for the extrinsic pathway, for the initiation of the coagulation. Calcium ions are important for bond between coagulation factors and thrombocytes. Proaccelerarin, that's the cofactor of one big complex enzyme. It's the cofactor of of number 10. So 5A is a cofactor of 10. Proconvertin is important for the extrinsic pathway and also for the initiation of the coagulation. So 3 plus 7, they start the coagulation. Yes. Number 8, this factor was first discovered that the deficiency of this cofactor causes hemophilia. This is the cofactor also, cofactor of factor 9. And then we have these 4 factors, 9, 10, 11, and 12, and all of them are serine proteases. So they convert other enzymes to active forms. Yes? Factor 10 is the protease of the common pathway, and the 9, 11, and 12, they are in the intrinsic pathway. Yes? And then we have number 13. If you produce the fibrin clot, you activate the factor 13 to stabilize this clot. if you here have a star, it means that they are vitamin K dependent factors. So have you already heard about vitamin K dependent things? We have about 15 proteins in our body that are dependent on vitamin K. Four of them are here. That's a prothrombin, proconvertin, then it's 9 and 10. But for example, vitamin K dependent factor is also osteocalcin that you have in bones. Vitamin K dependent factors, the vitamin K is important for one reaction in our body. Some proteins need to bind calcium. And if you want to bind calcium, you need to have carboxy group. And the more carboxy groups you have, the better bond you can produce. So vitamin K catalyzes, or is a factor of enzyme that catalyzes this. It catalyzes the carboxylation of glutamic acid. So at the end, you have glutamic acid that on gamma carbon has 2 carboxy groups, yes? So normally glutamic acid has 1, 2, 3, 4, 5 carbon atoms. So without this, it's the normal glutamic acid, glutamate, and vitamin K on the GABA carbon put a carboxy group, yes? And then we gain gamma carboxyglutamate. And this gamma carboxyglutamate has 2 binding sites for calcium, yes? These proteins are used in coagulation. For example, osteocalcin is used in bone structure, yes? And therefore, if you will learn in nutrition that if you have deficiency of vitamin K, you will suffer from bleeding, but also you will suffer from bone problems, yes? For you will have weaker bones. And now to the coagulation cascade. So before the break, I will show you the old model. The old model we have here. So, according to the old model, we have 2 possibilities how to start the coagulation. We have the extrinsic pathway, and we have the intrinsic pathway. And these 2 pathways joined here at factor 10. And here we have the common pathway. Yes? So here we have extrinsic, here we have intrinsic pathway, and here we have the common pathway. Yes? I will start with the extrinsic pathway. So, for the extrinsic pathway, you need to start the coagulation, you need 3 things, or 4 things together with phospholipids. The first thing that you need is tissue factor. Tissue factor, that's the mixture of proteins and phospholipids that are released from the damaged cells. Yes? So you can imagine that if you have the cell damage, there are some proteins that are, and phospholipids that are normally inside the cell, and if you have cell damage, then these factors are released. Yes? Or the damaged cell express different phospholipids and different proteins on their surface. Yes? So that's the tissue factor. It's the marker that you have somewhere tissue damage. The proteins that should be normally intracellular, and the same for phospholipids. This tissue factor, together with factor 7, and together with calcium and phospholipids, they produce something that is called intrinsic tenase. Yes, intrinsic for it's in intrinsic pathway. Extrinsic. Extrinsic tenase. Yes, for we will have also.
Sorry, what factors did you say? 7 and
3. Tissue factor is the same as 3. Yes. You know, only the factor 3 in here we do not use the Roman numerals. Tissue factor is very often written TF or tissue factor, or also TT as tissue thromboplastin. Yes? All other factors are normally with the Roman numerals. So together, these 4 things produce big complex that is called extrinsic tenase. And tenase, for it catalyze the conversion of factor 10, therefore tenase. Or you can also read extrinsic tenase complex. Yes? Therefore, you see that if you somewhere have a tissue damage, yes, it's very fast, it's a direct activation of number 10. And also in vitro, if you give the mixture of the proteins and phospholipids to the plasma, you will start the coagulation and you will produce the fibrin clot in 10 seconds. So this durates only 10 seconds. The intrinsic pathway durates about 47 seconds. 40. This only 10. So that was the extrinsic pathway. Now the intrinsic pathway. The only difficult thing is here, the first phase. The intrinsic pathway is started by the contact phase. Yes? Contact phase, it means the phase when the inactive factor 12 bind to the collagen. Yes? So not only von Willebrand factor can bind to collagen, but also factor 12 can bind to the collagen. Or this activation not only collagen can do, but also it can do the endothelial cells that are damaged.
How is this in vitro?
Yeah, isn't it supposed to be in vivo?
Not. You know, here this means that this intrinsic phase is more important, or especially this beginning, is more important for in vitro. Yes, for now I'm telling you the old model. According to the new model, this isn't important. But we have 2 coagulation tests, the APTT test and quick test. And the first, the APTT test, is started that you give something with negative charge that has also collagen to the plasma, and you will look at it. And therefore here is written in vitro. Yes? For this beginning is more important for in vitro. This beginning is more important for in vivo. Yes? So in this first contact phase, collagen plus factor 12 produce active factor 12. Yes? Or also this change can catalyze activated endothelial cells. In your books, here you will see, no, I heard somebody. In your books you will here also read that there is one process that can do the positive feedback. And here you will read about the kallikrein and high molecular kininogen, but it's not from my point of view you to know it. Yes, but in your books you will read it. That here is other possibility how to activate the factor 12. Yes? Now it's simply, if you have activated 12, you convert 11, If you have active 11, you convert 9 to active 9. And active 9, together with factor 8, with phospholipids and with calcium, they produce this together, produce something that is called intrinsic tenase. So here we have extrinsic tenase, and factor 9 produce intrinsic tenase. And if you look at them, they are absolutely the same. Here we have phospholipids and calcium, that's still the same. Factor 8 is cofactor. Here it was tissue factor. And factor 7 and factor 9 are the active enzymes that convert 10 to active 10. So this is the intrinsic tenase.
Let's say 8A.
8A, yes.
What activates A? Or
For also the cofactors are in inactive form and they can be activated. If you ask me how they are activated, I have to tell you that they are activated by thrombin. And therefore you see why in vivo isn't important the second pathway, the intrinsic pathway. For in vivo you will start with this. Here you do not need thrombin. You produce small amount of thrombin, then you activate these two factors and you will use the intrinsic system. Yes, that I will show you according to the new model. So active 8 means active 8, so activated by something. So this was intrinsic tenase. About intrinsic tenase you will also read in your books. And now we have the common pathway. Common pathway is 10, 2, and factor 1, and factor 13. Here we have tenase, for it converts 10 to active 10. And here we have other complex that convert prothrombin to thrombin. So how will be called this complex? No, it converts prothrombin. So prothrombinase. Yes? So if you put together activated 10, then the cofactor will be factor 5, and phospholipids and calcium to bind it together. We will produce active prothrombinase complex that is able to change prothrombin to thrombin. And that's the end. For thrombin is the molecule that can convert fibrinogen to fibrin, and fibrin can produce the fibrin clot.
So does the intrinsic pathway happen in vivo or is it only in vitro?
You know, the problem is that it depends, but only some part of it. Not this contact phase isn't absolutely important in vivo. This is important only in vitro. Yes. Unfortunately, this is used also in vivo, but we now think that it has different effect, not for coagulation.
It's much easier to use the other one.
Yes. This is faster. So according to the new model, we will use this. We will produce the thrombin, and this thrombin, small amount of thrombin, will activate the intrinsic pathway, but not the factor 12. That's according to the new model. Unfortunately, this conversion factor 12 to factor 12A, together with the kallikrein and kininogen system, is important for the regulation of blood pressure. So about this, you will learn in the second grade next year. For now, we know that this is important, but not for coagulation, but for blood pressure regulation.
When are those tests used?
These two tests are used, the APTT and quick tests are used for all patients with coagulation problems. That's the screening tests. Yes?
And why do you test for the intrinsic one if the activation always occurs on the extrinsic one?
There's the history. There's the history. You know, the old model was postulated in 50s, 60s, and it was a very big discovery, yes. For the old model was able to describe the most severe cases of hemophilia. And you know, the old model was unfortunately based on one premise, that we have hemophilia A, hemophilia B, and hemophilia C. All of them are in intrinsic pathway. Therefore, it has to be the most important thing. Nobody in that time understand that for the initiation is important this, and then the thrombin activates this. So if you do not have the intrinsic pathway, you have the initiation, but you do not have the amplification, so you will produce nothing. You only initiate the process.
Is thrombin included in the complex that activates the other?
What do you mean?
When thrombin has positive feedback?
No, yes, thrombin has positive feedback for thrombin converts 5 to 5A, 8 to 8A, and so, yes? And also the factors, yes, but it's not inside the complex. It only makes them active. And also, if you remember, the platelets were also activated by thrombin, yes? Thrombin is also able to convert the fibrin stabilizing factor, yes? So it's not a part of the complex, but it produces more molecules of the active complex. So everything what I said is written here, yes? Everything is written here. And after the break, I will tell you how it's in reality. But I think that the majority of you already know, yes? So after the break, the new model. So do you have any questions? So according to the new model, we know that almost all coagulation is initiated by the extrinsic pathway. They are, from the old model, we will take that the extrinsic pathway is initiated by factor 3, it means tissue factor, and factor 7. What's the difference from the old model? Tissue factor is released during tissue injury or during inflammation. But we know that in the blood we have still small amounts of 7A. Yes? So in the circulation we have still small amounts of 7A, and they wait till they meet the tissue factor. Yes? If the 7A meets tissue factor, it means it's cofactor, and it can start to do the action. Yes? Factor 7A can produce new molecules of 7A. So here we have the positive feedback. Yes, 7A auto-activates additional 7A molecules. Also, factor 7A, together with phospholipids and with calcium, produce the extrinsic tenase. So they activate factor 10. And you know that factor 10 produce the prothrombinase complex and produce small amount of thrombin. This small amount of thrombin isn't enough to produce a lot of fibrin, but this thrombin can activate the other pathways, the intrinsic pathway. Here you have the scheme, you can look at it at home. In the second phase, we have the thrombin that activates the intrinsic pathway. So it activates factor 11. So we do not start with factor 12, but with factor 11. Yes? Then it activates factor 5 and factor 8. They are cofactors. Yes? Factor 8 is the cofactor of intrinsic tenase. Factor 5 is the cofactor of prothrombinase. And also the thrombin activates platelets, and activated platelets, they express the receptors, they produce thromboxane A2, and they change their shape, yes? And also they put phospholipids on their surface by the flippase, and in this amplification phase you produce everything to make the coagulation very strong, yes? So you produce active cofactors, you activate the intrinsic pathway, you intrinsic the platelets, yes? So everything is prepared for a very heavy thrombin production, yes? So we can say that the result of the amplification is formation of more thrombin, and formation of reactive surfaces for complexes. And then we have the last, the propagation. In the propagation, we have something that is called thrombin burst. So due to the positive effect of thrombin that is able to activate the intrinsic pathway and to produce more thrombin, and this thrombin produce more thrombin. So after a few seconds, we produce the thrombin burst. And in the thrombin burst, we produce so many thrombin that it can convert a lot of fibrinogen to fibrin. Yes? So there's the propagation, the heavy conversion of fibrinogen to fibrin, and production of fibrin clot. And also, the fibrin is stabilized by the covalent bond between two chains. So this is the new model. So the extrinsic model, the extrinsic pathway production of small amount of thrombin. This thrombin activates some factors, activates the platelets in the amplification phase, and then in the propagation phase, the thrombin burst and production of stable fibrin clot. Yes? So we need both phases. We need, not both phases, both pathways, the extrinsic and the intrinsic. But at first we need extrinsic and then intrinsic pathway. So that's the new model, yes, of coagulation. At the end of the coagulation, we need to produce fibrin clot. So how the fibrin clot is produced? In your blood, you have fibrinogen. Fibrinogen is the globular peptide. It has 3 globular domains, 2D and 1A. And on the E domain, it has small peptide chains. And the thrombin does only one thing. Here we have fibrinogen. And if the thrombin cleaves these 2 peptide chains, here you produce the inactive fibrinopeptides. You have the active fibrin. And the fibrin can polymerize together to produce the fibrin clot. Yes, so quite simply. Yes, only you remove these small peptide chains from fibrinogen, and you produce fibrin. So this is called fibrin monomer, and this is called fibrin polymer. Problem is that here we have only non-covalent bonds. Yes, to make the fibrin clot stable, we need other enzyme that is called, it's factor 13, and it's transaminase. This enzyme catalyzes the reaction between glutamine and lysine in two different fibrins. Yes, so you will take one from this and one from this. Here will be, for example, glutamine, here will be lysine. And the factor 13 releases ammonia and produce covalent bond. So the difference between fibrin polymer without stabilization and with stabilization is the presence of covalent bonds between the fibrins. Yes? So there's the fibrin stabilization. Now I spoke only about the coagulation, so how to do the coagulation. But at the beginning of the lecture I said to you that one problem is if you start the coagulation on improper space, and second problem is if you aren't able to control the hemostasis. To control the hemostasis, we have the procoagulant factors and anticoagulant factors. The procoagulant factors you already know. So something about the anticoagulant factors. So factors that inhibit the hemostasis, hemocoagulation. So main anticoagulant factors are the blood flow. Why?
Because it's movement.
Yes. So you will take the coagulation factors out. Yes? And they can be inhibited by antiprotease system. Second anticoagulant factor is all products of intact endothelial cells. Intact endothelial cells produce only anticoagulant factors. For example, prostacyclin, that's eicosanoid, nitric oxide, or thrombomodulin. And then in plasma we have these three proteins that are also anticoagulants. Antithrombin 3, protein C, and protein S. Antithrombin 3 is the most important inhibitor of coagulation. We use it also in medicine. It has quite simple effect. It belongs to the serpine family, and serpines are molecules, are inhibitors of serine proteases. And if you remember, the majority of coagulation factors were serine proteases. So this inhibitor is able to inhibit all proteases in coagulation cascade. Especially, it has very high affinity to thrombin, it means factor 2A, and to factor 10A. Yes? It inactivates the factors. To make the inhibition more potent, in our body we have cofactor of this enzyme, and it's called heparin. Heparin is glucosaminoglycan with sulfates, and it's a very potent activator of antithrombin 3. Yes? We use heparin also in medicine. Yes? Many patients gain heparin, or it's better to say that all patients that the doctor put on the bed should gain prophylactic doses of low molecular weight heparins. Yes? For if you put patient on the bed, that's the procoagulation state. Yes? For you suppress the blood flow. Yes? So you suppress this anticoagulant factor, so you have to put there new. So all patients, or almost all patients, gain low molecular weight heparin. The last anticoagulant is protein C and protein S. About protein C and protein S, remember that antithrombin was inhibitor of proteases. Protein C is inhibitor of factor 5 and factor 8. It means of cofactors. So they act on different places. Antithrombin C act on proteases. Protein C act on cofactors. Yes? And if you do not have these cofactors, the intrinsic tenase and prothrombinate complex is inactive. So you do not have amplification phase. So you can start the coagulation, but you do not have amplification. About protein C, for it inhibits protein 5, you will learn one important disease. That's the factor 5 Leiden mutation. Have you heard about it?
An introductory lecture, I think.
What?
Our teacher from the introductory lecture mentioned.
Yes. That's a very common problem. You know, that's the mutation of factor 5. And during this mutation, you change the cleavage site for the protein C. So if you have this mutation, protein C cannot degrade factor 5. So the result is that you have prolonged activity of factor 5. And that's procoagulant state. Yes? This is the most common congenital thrombophilic state, and it's especially a problem if you combine this state with other risk factors. For example, with smoking, or if you take the hormonal contraception. Yes? So the problem is combination. Only the Leiden 5 factor mutation isn't so severe, but if you smoke or you take the pills, it's a problem. Yes? And therefore also young ladies can go to the hospital with a thrombosis. If they smoke, they take the contraception, and they have factor 5, they have very big risk of thrombosis. How to use this in medicine? The anticoagulant substances in medicine we use different. We use the heparin, that's true. Yes, so we use the same thing as our body. But then, the most commonly used to stop the coagulation is to bind all calcium, calcium absorption. So, if you want to gain plasma and not serum, you have to give in the blood these compounds, citrate or oxalate or ADTA. Yes, they are able to take the calcium from the plasma, and therefore the coagulation factors cannot accumulate. So that's the simplest way how to stop the coagulation. But for treatment, we use heparin, or we use the analogs of vitamin K. Yes. Especially in Czech Republic, we use warfarin. I think that in Germany you use more often Palental. And the effect of this factor is that it blocks the carboxylation of the glutamic acid. So you produce factor 2, 7, 9, and 10, but without carboxylation, so they cannot bind the calcium so good. Side effect is unfortunately that you have these vitamin K dependent proteins not only in coagulation factors but also in bones. So the side effect or the toxicity of these analogs is especially in bones of warfarin. You know, this warfarin was discovered as the poison against rats. Yes, so in all pharmacology books you will read that now we are using rat poison.
Sorry, another question. Vitamin
K inhibitor.
Yeah, protein C and S, they're dependent on vitamin K.
Yes.
But then they work.
That's a very nice thing. In pharmacology, you will learn that vitamin K dependent factors are not only those about I spoke, vitamin 2, 7, 9 and 10, but also factor C and factor S. And for the half-life of the factor C and S is shorter than the half-life of the coagulation factors. So if you want to start the therapy with this, at the beginning you produce the procoagulatory state for you suppress the production of factor C and factor S. So the beginning of the therapy has to be this together with heparin. After 5 days of this, you suppress also the production of 2, 7, 9, and 10, and you cannot stop administration of heparin. Yes? So traditionally, we give 5 days of low molecular weight heparin together with vitamin K inhibitor, and then after 5 days, we give only warfarin. You know, we should end, but can I only end with the coagulation? Yes, the white blood cells you can read at home, but the coagulation I will end. For we have only 2 slides till the end. The last phase of hemostasis was the fibrinolysis or thrombolysis. Yes? So how to remove the fibrin clot? That's quite simple. We have plasma protein that's called plasminogen. And this protein can be converted to a molecule that is called plasmin. And plasmin is able to degrade the fibrin clot. We produce the fibrin degradation products. Yes? Plasmin is serine protease that is specific especially for fibrin and for fibrinogen. Yes? On this picture you have how the plasminogen is activated or how it's inhibited. So focus on this. The majority of plasminogen is activated by this molecule, by the TPA molecule, tissue plasminogen activator. You have to know this molecule, for we use recombinant tissue plasminogen activator for treatment of thrombosis. Yes? So if you have, for example, pulmonary embolism or some severe deep vein thrombosis, the doctor will give you this tissue plasminogen activator. Or other way how our body can activate plasminogen is by urokinase. The inhibition of proteolysis is done by these 2 factors, by the plasminogen activator inhibitor. This part of the picture you do not have to know, yes? But this know that the tissue plasminogen activator is activator of fibrinolysis, yes? That's everything. Oh, last thing, coagulation test. No, that's the last thing. Coagulation tests, I spoke about them, that we have 2 main, APTT and quick test. Yes, you will do these tests in physiology next year. You will take your blood and then you will try to measure it. Yes? We did it with red blood, but you have to do it with your own blood. Yes? So these tests, APTT and quick test, are able to selectively measure the extrinsic or intrinsic pathway. Yes? But we know that according to our new model, it's different. Yes? But all tests are still used. So that's everything. So do you have any questions?